Welcome back to the PFC podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC podcast. This is Dennis, and today I'm with Rima. How are you doing today?
Hey, Dennis. I'm doing good. Yes, my name is Rima. I'm a combat medic with Kalinowski Regiment in the International Legion in Ukraine.
Hey, very good. So today, I would like to talk about unit safety and just like how do we stay alive long enough to do the actual thing we're here to do. So, while we did another podcast earlier with an NGO and how they do their own security stuff, and I'd like to ask as many people as I possibly can, how do you stay alive where you're working? So when it comes to security, especially in Ukraine, like how much emphasis do you need to put on just from the medical side, like security and staying safe?
It's a really good question. And a lot of us, especially our own brigades and our own squadrons, like my squadron, my med team, we all have our own standard operating procedures. And pretty much 99.9% of the time, the emphasis is put on personnel over equipment. And that is, if we do run into a situation where our safety is compromised or we've got an FPV chasing us or anything like that, it's to get out or move as quickly as possible and not worry about the equipment and just try to stay alive.
Okay. So, when it comes to when you're not actually doing the job, you're training to do the job, I guess, do you guys go through like some kind of tactical training as far as how to move without being seen kind of things, or how do you practice that stuff?
So we get that training. So all of us, even if we're medics or med team medics or stabilization, so like not necessarily infantry, we still go through infantry tactical training in basic training. And then we also have our own SOPs about how to move. 9 times out of 10, we're in medevac vehicles or in stabilization points. And for my specific situation, we are attached to another larger brigade, so we would follow their standard movement procedures, which I won't go into. But again, the emphasis is put on personnel over equipment. So we move out, we move together, and we get out as quickly as possible, either with, if it's a stabilization point, it's going to be with vehicles or whatever transport we're provided. If we have an FPV chasing us, we eject from the vehicle and find the nearest point of cover.
Okay. Now obviously you have to have some kind of gear with you. Some stuff is more important than others. Yeah. So in order to maintain that capability, because a medic without their gear is essentially just a bystander with a bunch of knowledge,
100%, 100%. So when I say over equipment, so essentially the only problem when an FPV is chasing you, unless it's strapped to your back, it's not coming with you when you're ejecting from that vehicle. That's just it. We swallow the loss and then we have to either return to base or find, a resupply. But if it's the stabilization point, for example, you're able to grab, like I always have my ruck with me at the, my med bag at the stabilization point. Your helmet, your plate carrier, and your weapon, those are always technically on you. So those things come with you as well. But it's like whatever can be strapped to your back or you can carry is what's coming with you, pretty much. That's it. So.
Like that security, do you obviously if you're traveling and somebody spots an FPV, you have to react to contact kind of thing. Is there like the more medical personnel you put out towards security, the less medical personnel can be focused on the medicine part, right?
Yeah.
Do you have internal security or do you rely on outside units to provide that security?
That's going to be coming from outside units for like the med team or part of our infantry. If we're doing stuff like that, also sometimes we're just on our own and we'll have to do it for ourselves. That's why we have our weapons. That's why we have our training. But that's, par for the course. Like unfortunately here it's a little bit more fluid, and we don't always have like solid planning because there isn't enough personnel, or we don't have the opportunity to have like the perfect situation because of that as well. So like, it's going to be 50-50. It depends on the mission that we're doing. If it's the stabilization point, then we've got the other brigades around us to provide security. And again, we're also capable of providing our own as well if it's needed.
Okay. So Sam was mentioning, like, when you're moving out to pick up a casualty, in his case, it was essentially you have the medical provider and you have somebody else essentially scanning the skies, looking for drones. That seemed to be what he was emphasizing the most, is the drone threat. I'm sure there's many other threats on top of it. Is that pretty normal?
So for us within our units, within our medevac team, we have our drivers and our medics that go out to get casualties, and everybody's on spotter duty if they're not in the back of the rig. So like, we all are responsible for spotting if we're not in the back of the rig. The issue is also that in our area of operation, the drone threat is so bad that evacs are next to impossible at the moment.
So obviously, so I guess stabilization at the front. So you're definitely prolonged care, even though they have, you may have, stabilization areas or roll twos or triage areas. You still have to, essentially, you just can't get there.
It's 50-50. Some of the other brigades are still attempting it. But it's so bad that there's definitely more PFC going on. And that's where I wanted to kind of address the telemedicine part of this whole thing. We have infantry medics on the ground that are combat medics that are like trained up all the way. They need the PFC telemedicine. So that's what we're providing when we have to from the stabilization point, or, and that's all from our phones. Because they don't have a way of getting out and we can't get the patients from them. So that's where the telemedicine comes in. It's not that there aren't medics on the ground. We have, at least in my area, and let me emphasize, I am not speaking for all 1,000 kilometers of the front line. And I think that that's the hard part, is that nothing is uniform in Ukraine. So like, it could be that there are some units that are doing CLS over the radio. That's not the case for us, but we are doing PFC over any sort of telecommunications for our medics that are on the ground, because we can't get the heavy casualties out. We are still having guys come through the stabilization point. Lots of heavy casualties. Obviously, we barely have any light casualties, but the ones that we are getting that are light casualties can exfil on foot. And that's why we get them, because they can exfil on foot.
Okay. So when it comes, I guess, at least, what was I saying? The medics, just from what I heard, since I've never had to train any of them, like the medic training is like 5 days. Is that your experience? It depends?
It depends.
Is that on the long side or the short side?
It depends on which level. So I'm also a TCCC instructor. So I teach CLS and I also teach CMC with a group of other medics. Our CLS class is 5 days. Our CMC is 9 days, because that is what that is what commanders are willing to allow their medics to leave that amount of time. That's what we get. And so we are cramming everything we possibly can to train them to the best of their abilities. And we test them over and over again to make sure that the material is sinking in before we let them graduate. But this is, I really want to emphasize to the people out there that are going to possibly have an aneurysm over this. In an active war zone, we don't have enough medics already. And so letting them out for, say, something like 16 weeks is impossible. We can't do it. And it's an active war. And it's like, if it was, there's no pause breaks, right? So like, we can't just be like, okay, well, let's just pause for, a month and a half or 2 months so we can, but instead what happens is we teach them for how long we get them. And then we do refresher courses as much as we can that are shortened, but emphasize the important part. So like we'll emphasize on the medicine and pull out for the refresher part, we'll pull out the tactical portion because we've already done that, but we'll emphasize on the medicine and have them, show us and demonstrate that they still understand the medical portion of what we've taught them. Because in the end, we know how to soldier. We have to know how to do the medicine more than we have to know how to soldier in the moment that we have the casualty.
Yeah, absolutely. People forget, like, war is really bad. And like you said, there is no pause button. And
no,
you have to do with what you have. So I absolutely understand that aspect of it. So, I mean, T-TRI-C, which is essentially just the basics of combat medicine, can be a pretty lengthy process. So how do you go about carving out the things that aren't so important so you can emphasize the things that are very important?
That's a really good question. So like we teach the entire course in 9 days, which I know sounds like it's impossible, but trust me, adapt and overcome is the slogan of this entire war. And we do it. But we emphasize especially on the basics first. The first 2 days are always on stop the bleed and the basics. And then we start with IVs, IV administration. Like we follow the entire March protocol all the way through, but we try to emphasize for the most part meds administration, med math, vital signs trending, vital signs spotting, what different vital signs could mean, the difference between shock and tension pneumothorax. Like we try to make sure they can spot what they're dealing with beyond a shadow of a doubt. And also knowing how to do blood transfusions. Those are really important if they do have to end up doing them in the field. Field blood transfusions only became legal in Ukraine very recently. So like this is training that we've been trying to emphasize. And by recently, I mean, it's been about a year, but it's still not as far forward on the battlefield as we would like. In the stabilization points, it's all, we're blood forward. That's no problem. But like if they have to do field transfusion, like we're still training on that more people than we would like. So we try to just make sure that they are solid on stop the bleed, meds administration, how to do IVs, doing PFC. Like it's like PFC light. Like we try to like have them understand trending vitals. We want to make sure that they, are watching and we're noting down the meds that they give. And that's kind of what we're doing with some of our medics on the ground right now. So like I'm on one of the chats that we have, we're monitoring 3 patients right now. So they tell me their vitals every day. And I, emphasize with them, like, we need to know what vitals are and what they're trending. So we know what's going on with their injuries and infection, spotting sepsis, et cetera, and so forth. It's like stopping it before it starts. So that's kind of like where we're going with that. So
with these telemedicine calls or chats, however it works, I guess what are the major questions that you're being asked?
Usually it's maintaining wound care. That's maybe our biggest ones, is to maintain clean, dry wounds, watching for infection, watching vitals to see, like, is there a temperature? Those are the main questions. Most of the medics know what they're doing in terms of meds. They have no issue understanding what antibiotics to give, how much to give, when to give it. It's more they worry about amputation injuries and, how to do field debridement, which is something that they have to do in terms of infectious tissue and at least trying to deal with keeping the infection at bay. They're monitoring tourniquets. There's been some situations where people have had tourniquets hunt for 3 weeks. So, that's the reality that we face because we don't have any way of getting in faster than that isn't going to result in a lot of death. One instance, we had 6 guys go in, 1 guy came out. So it's just too dangerous right now. So the questions are always going to revolve around wound management and vitals management. And then anything that regards if they need medicine, what do we need to drone drop in? That's what we are usually like. We get reports on how the casualties are doing. They ask questions about how to maintain their wounds and how to keep them clean. And then what supplies they need.
I mean, do they have access to soap and water?
Yes. And so we do let them do that. They also have a lot of access to normal saline as well because we drop it in. So they can use normal saline. They also know they can use, we try to have them save the water for the casualties to drink. If it's potable water, if it's technical water, then, soap and water should be okay. But we also need to make sure, I'd much rather that they use normal saline if we can give that to them, just because we need to ration the water a bit.
Okay.
Yeah.
So then I guess hello? That's okay.
I have no idea what happened there. That is welcome to technical difficulties in Ukraine.
Not a problem. Not a problem. So kind of, let's see, talking about like the stabilization points. So obviously you're going to have more gear than what your aid bag is holding. If you were to receive a threat, like, hey, we have inbound whatevers, how do you prioritize what gear to move out?
So for us, it's the first priority is what we're carrying. And that's going to be, I'm always like I have a RATS pack. So my RATS pack is coming with me. For our brigade that we're attached to, I do not know what their gear priorities are because those are their standard operating procedures. I think that's something we would be informed of if and when that came to it, and we would be given the directives once, we would have to help them move anything out. If it's something like if we're with our ambulance, then we are prioritizing, obviously, getting whatever, if we have to help them move their supplies, we will put it into our ambulance and move out, that kind of thing. But it has to be like fast, obviously. So that's the other thing that we're looking at. Also, for some reason, I'm getting a video recording error. So it says to reconnect. Are you able to record right now?
I definitely hear you.
Okay.
Here, why don't you disconnect and reconnect, and I'll just edit.
Okay, let's see if it does it again. Hopefully not. But yeah, so the emphasis would be placed on whatever, if our advanced directives come in from the other brigade, then they'll give it to us when the situation occurs, and we'll help them with whatever they need. So that's essentially what we would do at that point.
Because one thing that we do is we'll put color tags on whatever gear, like surgical instruments or things for resuscitation, so that when I need to move, I can tell somebody that has no medical knowledge, like, hey, get everything with red tags on it.
Oh, that's actually really good.
Just so that I don't have to explain what is this when we're under stress, right? So we just tag like items so they know what to grab. But I don't know. I guess when it comes to security and I guess maybe even telemedicine problems, what else do you think people, or do you wish more people knew about?
I wish I think when everybody comes from a place of having every single resource they could possibly have and access to all those resources and never having to worry about having that kind of access, they don't understand what it means when people don't have it. And so, well, why can't you do this? Well, why can't you do that? Like you could do this. And I'm like, we have nothing. Like we are entirely reliable. Like, let me put it this way. We are mostly reliant on the outside world for our medical supplies. Like they don't come in from internal. Like we don't have the support that, most military medical structures have. They get it from their army. The army doesn't have it. So we have to get it from the outside world. And that means the same thing with how we take care of ourselves too. Like if we have to get out, we have to emphasize what is the most important. Number one is personnel. Okay. Then this next thing is your equipment. I also know that there are some directives in some parts where it's just leave it all behind and get out. And that's sometimes just how it is. And in terms of telemedicine, we have to do what we have to do in order to keep our patients alive. And even if I haven't directly put my hands on this casualty, I am now part of the group that helps keep this person alive in a very austere environment. And that's, I have that personal responsibility as well. And so we have to not only take care of them, but we also have to take care of the medics that are doing the heavy lifting on the ground and don't get a break and have to deal with a lot of patients at the zero line without much resources. So the best thing we can also do for that is make sure they have everything they need. And that will also include heavily relying on the outside world for things that we might not be able to get readily on our own, that we're also responsible for ourselves to get. And I think that that's just unfathomable to a lot of people. And I try very hard to explain this in the best way that I can. That sometimes you can't always get what you want,
Yep. Oh, yes. I am well aware of that particular problem. But that's the nature of the environment, and that's why I've always found that knowledge is much more important than the gear.
Definitely.
You can't buy your way into good medicine.
No.
You just have to know. You have to know what you're doing.
I completely agree with that. And that's why we emphasize too on so many different things in terms of improvisation. Like if you don't have this, then you need to do this. And you have to understand each and every part of tactical medicine, each and every letter in depth, because if you need to know the how, but you also have to know the why in order to do good medicine if you don't have the tools to fix the problem. Yeah. And so like this is why I have the Instagram page that I have, because I want to be able to emphasize like the issues we run into, and also get at the parts of TCCC that's not always well understood or well explained, because we blaze through it and we think we know everything, but people haven't mastered the basics before they try to get on like the halo skills. And that's part of the problem, is they don't understand the foundation of it before trying to get to the really complicated parts.
Oh yeah. No, the complicated stuff is fun to learn because then you feel more advanced. But if you have not mastered the basics, you will never have to worry about the advanced stuff because your patient will die. Exactly.
And this is where being really good at stopping the bleeding, being really good at making sure your airways are clear, and also really good basic wound care to stop infection. It's all basic stuff that doesn't sound very exciting, but that's what saves lives. It's not, the random crike you think you're going to perform, it's this stuff. And so that's the main thing that we encounter for the most part.
So speaking of hemorrhage control, you're well into winter in Ukraine.
Yes.
So guys are wearing much more clothing, layers of clothing. I guess, how is that? Have you seen, how does that affect hemorrhage control and actually getting to the wound to do your thing?
So as always, there's some, problems. It depends on how the level of training is for the soldiers out there, because it's not just our brigades, it's other brigades, and we get everybody. And so we can see who's got what level of training by how their tourniquets look, or where they're at, or how they've put them on, or if they're tight or loose. winter plays a problem with that, because if they don't have the training, they just kind of throw it on top of the clothes, and it's kind of like a slap it on and hope for the best type of situation. But we do see more people that are cutting all the clothing to get to the wound, at all layers too. It just depends on who's dealing with the guys at the zero line. At the stabilization point, it's 50-50. We either get them where they have them where they're supposed to be deliberately, like under all those layers, or we've got to cut all the way through all the clothes and check everything.
Again, I guess with winter, have you noticed any differences in wound patterns lately?
No, they're all kind of the same. Everything is coming from FPVs. Sometimes it's every once in a while, it's a couple of GSWs, but like more often than not, everything is coming from either PFM mines, which are what we call toe poppers, or FPV drone explosives. It's all kind of the same. Shrapnel injuries, or it's mostly shrapnel injuries, and a lot of TBIs. Yeah.
I guess any other topics that you're thinking are really important for the outside world to know?
I think it's really just, I think we've covered everything, but I would love to emphasize the fact that, this particular war is all about adapting and overcoming very difficult situations in tactical medicine, and understanding that we can't always do things the conventional way. And we'd love to be able to do it that way, but that we are faced with a lot more issues, and we can't always do it the way that we would love to. And in general, also just with security problems as well, it's, you kind of just have to act in that moment. Sometimes you can't always have a standard operating procedure that will be used across the board, because every situation is different. And that we just have a general idea of what we're supposed to be doing in terms of security. But if something goes wrong, we have to act quickly. And it's essentially personnel over equipment. So we do the best that you can.
So speaking of the FPVs, maybe not without revealing any specific tactics,
Sure.
but in general, like how do you hide from an FPV?
You find cover. You can't, like, we have like drone detectors that we can use to at least like figure out if they're in the air. But like in the past, we used to have these drone guns that you could just like bring them down with radio frequency, but fiber optics don't react to that. So like that doesn't work anymore. Also, we have gone back to a very not normal, how do I describe it? A very, I guess, like American style of shotguns, just shoot it down. And that's kind of the other defense mechanism we have. But hiding involves pretty much exiting the vehicle and finding cover. That's really the best we can do.
So the fiber optic, I know in the US we have a missile that uses a fiber optic cable. And the weak point of that fiber optic cable is that it's not very flexible. And so essentially it wants to just go in a straight line is what it wants to do. Yeah. But if you were to move laterally, then potentially that fiber optic can break.
That is true.
Have you found anything similar?
Not in my experience, no, not yet. So like that's something I can talk to some others about, but that's not something that's happened in our experience yet. For the most part, our issues are still with FPVs.
Well, awesome. Very good. I really appreciate you jumping on and talking to us.
Anytime. I love your podcast. I listen to it all the time. It was something that I started to listen to early on in my medic career, I guess. And I think you guys are an incredible resource. And I send your podcast to all my students. So I thank you guys for what you do for us, because we can also, continue learning from these stories that you post.
Hey, well, thank you very much.
No problem. Thanks, Dennis.
That that's it for today's podcast. Make sure to go to our website, www.prolongedfieldcare.org. Check out our free downloads and a ton of other helpful information. Grab a bag of our fresh roasted PFC coffee, links in the description below, and stay on the bleeding edge of combat and austere medicine. This is Dennis for the PFC podcast. Out.